for later, you can raise your hand later on and ask the questions directly. So first of all, normally your camera and microphone should be switched off automatically for the first part of the webinar, but please check whether this is the case. And this webinar is being recorded. Yes, thank you, Ben. And as was requested by the speaker of today. So now I'm very happy to introduce the speaker of today. We are here with Dr. Janet Michel. She is an epidemiologist and health policy and systems researcher with over 25 years of experience in health systems across sub-Saharan Africa and Switzerland. She designs research and interventions for impact and has developed several frameworks, including policy, digital tool, and impact evaluation frameworks. So please, Janet, take it away. The floor is all yours.
Thank you so much for that introduction, and I'm really excited to be here. I think you have introduced me and work that I do. And those who don't know where Zimbabwe is on the map, that's where I come from. And so that's the region that I really have experience working in, and now also Switzerland. So when we are talking about impact evaluation or impact in palliative care, I just want to highlight that we are also talking about staff well-being, but patient well-being, as the two are intertwined. But for the purpose of today, we are going to focus on patient well-being. Hopefully, we will have another webinar dedicated for staff well-being. I'll touch a little bit on what impact is and how research and programs are being implemented today, why we are failing, and you know, the geopolitical shifts before I introduce the framework itself. So I don't know what comes to your mind when you hear the word impact. For some, it might be something like this. But the good thing about the two pictures is we can see that a hammer has passed through there. There is evidence. The hammer has passed through there. For me as a Zimbabwean, once again, it's a baobab tree. Why I say that is a baobab tree changes the lives of the people around. It provides nourishment. The leaves can be used as vegetables, the fruits, the bark can be used as medicine. So the baobab tree changes the lives of the people around, including the animals and even the soil, as the leaves also change the soil around it. So that's impact. So when we are talking about research impact, what exactly do we mean? We are talking about research that leads to improvements in health, in the economy, in the productivity, or reduce the burden of diseases. So this is a demonstration of benefits that go beyond the academic knowledge base. So it's really a societal, cultural, environmental, economical benefit, and just reporting and saying, okay, we supported so many scholarships. That is not research impact. The question is, what have those people who have been funded through these scholarships, how have they changed the lives of the community served? And it's also no longer sufficient to say I published in Lancet or I published in Science. This does not count as research impact. So we need really improvements beyond the academic base, and you know, in your case, it's more changing the lives of palliative patients and end of care patients. So when we talk about interventions, impacting interventions, what is it that we're talking about? We are saying that the observed change in the outcome is solely attributable to that intervention. So there's causal inference. And when we're talking about interventions, we ask 4 questions. First, to what extent can the impact be attributed to this intervention? And did this intervention make a difference? For whom, right? We want to know, to have a clear context, mechanism, and outcome pathway. What was the situation before the intervention and now show us the situation now. And also, we really want to know if it made a difference for everyone because of equity. It might make a difference for only one segment of the population. So that also has to be captured. So we are really talking about opening that black box, trying to identify what exactly caused the change in the observations in the outcome, and how has that come about. So this clear context, mechanism, and outcome pathway. Hence the importance of stories or qualitative data in addition. Up until now, impact evaluation has only been done through experimental designs or quasi-experimental designs. So randomized controlled trials or before and after, trend analysis, intermittent time series, dose response. But we know that not all phenomena can be studied this way. Human problems cannot be randomized. I cannot say you have cancer and you don't. And you cannot say you have HIV and you don't. So what about people and working in such contexts, observational contexts? Are they not supposed to demonstrate impact of their work? So this changed recently when, everyone was like being asked to demonstrate impact. And the challenge was this led to black box evaluation. So people just really scurried and started to avail evidence or impact outcomes without really demonstrating how their intervention has produced that particular outcome. The unfortunate thing of harvesting outcomes is that you tend to harvest the positive things, but we also know that there are unintended effects of any intervention, and those should be captured too. But this way, when people scramble, these are not captured, and there is that risk of moral injury and loss of trust. So failure to capture impact is by design. Let's look at a typical study. What happens? So usually you identify a research topic, you do your literature review, you formulate your research questions and hypotheses, you work on your methodology, you do data collection, analysis, and people run and write and publish. Rarely do people, after identifying a research topic, go back to the community served and say, this is the topic that I'm going to work on. Does this resonate with you? Is this the priority area that you want to be worked on? And also rarely, after data analysis, do the researchers go back to the community or the community served and say, these are our findings. Our intervention seems to have produced these findings. Is this what you are seeing on the ground? Have you also, can you confirm this is what you have seen? So the only time researchers are really seen is during data collection. And this is also really driven by the publish or perish factor. Okay. Looking at, for example, women's health, an area that I'm currently working on. Again, we are saying women's health is neglected, it's under-researched. And the reason is, for a long time, men have been the default body, or in clinical trials, women have been systematically excluded. And hence, whatever we take, the drugs that we take, have been tested on men, and it's sometimes actually leading to harmful effects or being ineffective because women were not involved. So this really demonstrates the importance of involving the key stakeholders. There is another issue, which is funder expectations. So consider a program that has to run for 3 years. And the key stakeholder engagement alone can take to 1 year or longer. And then it takes another year to a year and a half just to get the baseline data. You want to really make sure, if you want to demonstrate impact, you capture that. So this leaves one with 6 months to implement an intervention. And at the end, the funders want to see results. So what happens? People scramble and come up with outcomes and report these outcomes, but looking at this realistically, what can one do within 6 months? And if they don't do that, they don't get the funding. So there's that systemic disconnect with this funding trap and our unrealistic expectations, leading to fudging of numbers and also cutting of corners. So it's really because of another factor, which is people do not think of impact at the very beginning. So this is what we should do. Sit down before we even start an intervention at design stage and define what impact are we trying to achieve. But what people are currently doing in reality is people chase the money and short-term thinking, and it's a reactive approach. I want to give you a few examples of a program called this Structural Adjustment Program, which was run for a long time. The aim was really to improve the economies and it was because of this economic crisis. It was initiated by the World Bank. But what actually happened is it led to cuts, severe cuts in health and education, and actually increased poverty levels. So the lessons learned is it's so important to also take account of the context, but really involving the community and not waiting for a long time until the end. They could have, if they were if they had monitored this, tracked the implementation of the theory of change, they would have identified that this program is actually going in a totally different direction than was intended. This could have been captured earlier. There's another a program, which was this aggressive infant formula promotion in the low and middle income countries. So they actually formulated this as formula is really a modern alternative to breastfeeding. There was aggressive marketing. Some professionals were actually paid to promote this formula. What happened is it undermined local culture and traditions of breastfeeding, but it actually led to a mortality of infant and child mortality due to diarrheal diseases and malnutrition. So the core lesson is it's so important, again, to consider the context, but also another thing is the involvement of public health messaging must be actually protected from commercial co-opting and involve the local stakeholders. I don't know how often you see this in palliative care and end of life care. You can jot that in the comments. Thank you. So in palliative care, and are there programs that have been run for many years without much impact? And are you seeing interventions where there is no positive effect on the patient life, rather more unintended effects, but the programs are still implemented? Also, kindly jot that in the comments, and then we can talk about that at the end. There is another factor, research fatigue. So the communities are tired of researchers coming in and out, doing their research, but their lives are not changing. And you might have seen that in your communities where patients are not interested in research anymore because people come and they just collect their data and off they go and publish, and there's no benefit, no real change in the lives of the patients. This has also to do with governments that are, they're very careful because of the spending, and the resources are getting less and less. And they are, for example, the UK, the US, Australia, and also Zimbabwe have come up with this research excellence framework. They are now asking for accountability for money that is spent on research. They want that people who receive this money, the institutions that receive this money, produce evidence of benefits that go beyond just research. And they're also using this information for benchmarking and for allocation of funding. They want to get the best value from the research and interventions, but with real evidence on the ground. So the funding itself, the landscape is changing, and this has led to this rise in demand. So we know that our globe, the whole world, globally, we have more conflicts, there are geopolitical shifts, the cuts in the research funding, but also we saw the massive resignations in 2022 where the healthcare workers really were like, is this the, do I want to spend my time in this field? Is the work that I'm doing meaningful? So all these factors are actually working together. Are based on John Kingdon's policy window theory. That means we have the political stream, we have the problem stream and the policy stream coupling. So all these things are working together, creating a policy window. And this is demonstrated by why the WHO Alliance strategy for 2024 to 2028 is saying we all should aim for impact in health policy and systems research. So this makes impact indispensable. If you want to even if you want to publish, they are now asking, have you involved the patients? And so in nursing, it's all about really making sure when we say we have interventions that promote health, you need to demonstrate how. That the interventions that are leading to recovery, we need to identify those and show the evidence, or as it is in palliative care, that are leading to a peaceful death. So impact, it's really an opportunity because there are misconceptions when we do programs or run, when we carry out programs and we do monitoring and evaluation. Monitoring and evaluation is not the same as impact evaluation. So when we do M&E, we are tracking the use of program resources. But when we are really tracking impact, we are tracking the implementation of the theory of change. So if we carry on doing what we are doing right now, impact will continue to evade us. When I speak of impact, and I started talking about impact to researchers, these are the responses that I got. One is resistance. Then researchers and program managers, they say it's difficult to demonstrate impact. And they say, we work in environments that are very challenging and we cannot produce impact. Others, there's this lip service reporting where they say, yes, impact is important. They put it on their website and you have a tab, impact. But when you look, you see that it's actually activities and outputs that they are reporting. And then there's another group where they say, look, like I said before, they are out there. They say my life, this is the job that I do, and my supervisor says I have to publish 3 papers, and that's what I do because we all need to put food on our table. It's really understandable. And so it becomes like really an elephant walking on a tightrope. But my question to you is, if research, and I think we do research because we believe that it benefits the society, why then are we struggling to demonstrate this? And also, if we hide behind not having resources to measure that research, what else is getting missed? If we don't have enough resources, should this not be more of a reason to demonstrate impact? Because we say our future depends on it. Europe's future depends on research. It's very much so. Asking for impact evidence is very much in line with good clinical practice, something that we all do as researchers because we want to make sure that we do good, we cause no harm, and there's that respect, and we want to ensure justice. And I asked AI, what would impact look like in palliative care, and really AI got it. There is a before. We really see what the situation is like before the intervention, and then you see the situation, what it is like after the intervention. You can see the difference that this intervention has made in this person's life. It's also important to say there's need for impact in end of life and palliative care because there are physical and psychological symptoms that the patients suffer from, a high burden, which often feelings of hopelessness and depression. So we want to identify interventions that help with this. There are also communication gaps. and patients really feel then ignored or not involved. We want to know how best, what interventions help with that. But also we have this barriers to care, with sometimes aftercare being very, very limited. So we want to know how best, what works best for them. And then the caregiver burden itself, which is so taxing and has a toll on its people. So we want to know what interventions would reduce that. And looking at our societies right now, we have an aging population with chronic illnesses and the complexity that this brings about. What interventions produce impact? We need to know it. And we have AI and the advancement and the need for even more personalized, person-centered care that demonstrates impact, because we know that the digital tools are a double-edged sword, right? They can do good, but they can also do harm, as we have seen with TikTok. And then you also have this emotional toll and a human resources for health shortage in the that is now, but also projected. We will have 11 million human resources shortage by 2030. So what interventions help to make sure that this to ameliorate this and ensure positive patient impact? And we have rising healthcare costs and rising poverty levels even in Europe. So this is a critical opportunity to embed impact-aware methods at design stage, so we can actually achieve impact and through the effective and efficient use of resources. But it demands really a shift from reactive evaluation to proactive designs, and this way the good thing about it is that impact is actually forcing managers and researchers to think about impact at the beginning and also to include the stakeholders. So the path to impact calls for engagement and honest partnerships with all stakeholders. And I think it's good that the University of Freya has actually has such opportunities, and there's need for structured engagement that really allows for frank but safe conversations about what is truly feasible, so we can shift resources towards what is known to truly work better. But it also requires that managers shift from setting unrealistic demands to co-creating solutions with those on the ground, with those people on the ground that have actually contact to the patients, who know what is working and what is not working. The good thing is that this is a bridge, that there's this common understanding, and that we all want, I think managers too are interested in real impact. So I'll introduce the actual framework. What is a framework? It's a tool that outlines parameters for an evaluation, which serves as both a guide and a checklist. And so there's more that focus. We better prevent, we better do this proactively than wait until somebody comes and says, show me your impact, and then you realize you don't have the data. So there are 7 central tenets. I'll start with 1, the involvement of key stakeholders in core design, monitoring, and evaluation. And then the importance of actually designing, developing together with the stakeholder a project or intervention theory of change. And then 3 is the baseline measurement of outcome of interest. What is the situation now? And then the use of mixed methods, because we know that stories alone will not tell us who benefited and to what extent. So it doesn't tell us how many people benefited, but quantitative data itself does not tell us the how and the why. So it's so important to have mixed methods. And then midline measurement of outcome of interest. You want to at least have several, but about a minimum of 3 data points to do a trend analysis. And the endline measurement of outcome of interest, validation and of findings, and co-creation of recommendations. So the good thing about this, as you can see, this is a very simple language, right? Everyone can understand this. And it's also different from when we hear somebody talking about R squared, how the model fits the data. It's not important to a patient. If they're saying they have pain, they're not interested in how the model fits the data. The question is, has the intervention done away with my pain? So it really helps to do away with that jargon that researchers have been hiding behind. And it's really built on the principle that everyone belongs at the impact table. So the 7 central tenets is by including the first one, the stakeholder engagement in co-design and implementation, their perspectives and assumptions are taken into account. And it's also like the contextual knowledge, and it fosters ownership and accountability. And the number two, the central tenet number 2, the theory of change. If you don't describe how you expect the change to happen, there's no way another person or yourself can tell whether you have reached the set objective, because you never describe what the objective was and how you wanted to get there. So it's really so important to articulate a theory of an intervention theory of change with clear logical pathways of activities, and also making the assumptions explicit. With mixed methods, combining quantitative and qualitative measures allows for data triangulation, as I mentioned before. And with the baseline, midline, and endline, you have 3 data points. You can at least do a trend analysis. But with the validation and co-creation, you're actually involving the stakeholder and saying, have we reached that set objective? And that's so important. The voice of the patients matter. So how would we apply that in a palliative and end of life care? So when we say in nursing, we say we are assisting individuals sick or well in performing activities contributing to health, recovery, or a peaceful death, which they would perform unaided had they the will, strength, or knowledge. And here they don't. So that's what we are doing, right? So while we are doing that, we want to make sure that we actually utilize all the 7 central tenets. And depending on the identified need, is it activity of daily living that you're working on, or are these instrumental activities of daily living? And together with the patient, you develop an intervention theory of how you want to reach that objective. So we say impact begins and ends with the patient, right? You at your baseline, when you do your assessment, let's say if the person and the patient is in severe pain, and their goal, what they want, is to be free of pain. So together you design that intervention theory. How do you do that? So with a theory of change, you start with the desired goal, which is here, free of pain, and then you work backwards, identifying the outcomes that ought to be in place, and also the causal relationships leading to that goal. So it's really starting with the desired goal, and then working backwards to identify what is needed, the activities. So I have an example. Let's say this patient we take this patient as an example. So we have a theory of change, which can be a statement or a diagrammatic depiction, where we say, if we leverage multidisciplinary expertise, validated assessment tools, and both pharmacological and non-pharmacological therapies, if we leverage that, and care teams implement personalized interventions grounded in patients' own definition of comfort and quality of life, then personalized, responsive, and dignified palliative care is assured to every patient. So we have the patient saying, this is my goal, this is what I want, and together you come up with the way, which is the pathway to getting there. So these interventions then will produce some outputs, like tailored care plans, and then the outputs will lead to this improved pain and enhanced functional ability, and consequently sustained pain relief, preserve dignity, or maximize quality of life. But it's so important to have these assumptions tested. So for us to achieve this, we need to have strong patient-provider trust. We need to test this and make sure that it is a true assumption. Is there effective communication? Is there a reliable access to care resources? So it's effective when it's co-designed and continuously adapted. So a theory of change is something that has to be revisited. So in this model, the impact forms a closed loop originating from and returning to the patient, and ensuring that this care remains very personal, responsive, and meaningful to that particular patient. The fundamental premise is, as we know, it begins and ends with the patient. At design stage, you can also have the theory of change presented this way, but the assumptions are so important, but also taking into account other factors, external factors, the disease progression, for example, and you need to revisit the theory of change. For example, if the social support changes. So these are things that the theory of change has to be revisited from time regularly, and not just designed once and put aside. When we have a theory of change like that, we have a clear context mechanism and outcome pathway. If we get these outcomes, sustain pain relief, preserve dignity, or maximize quality of life, we go back and see what has enabled this. And then we realize we have the multidisciplinary expertise, we have a personalized intervention for this pain, and we have the baseline, midline, and endline data. And what enabled that? Then we realize, okay, it was because this strong patient-provider trust, the access to resources, but we also know that if, for example, the situation changes and all of a sudden you have staff that is poorly trained and communication gaps, then these outcomes are bound to be affected. And so it's so important to monitor and the theory of change and the assumptions regularly. Let's look at the nursing process. You do your assessment, diagnosis, planning, implementation, and evaluation, which is really, really important. But the challenge, which is something that needs to be strengthened, is with the nursing process. It's more looking at what the nurse is doing, but it's so important to remember to involve the patient as an active player. So that traditional patriarchal approach to healthcare, where the nurse or the doctor is the one who knows, and the patient is more very passive, is not really conducive when we want to talk about impact, because the patients feel disempowered, they feel unheard, and not engaged in their own care, affecting the patient outcomes. With theory of change, what is being done is we are actually opening this black box. So it's about what is actually happening in the middle that is leading to these dignified outcomes. If we look at other frameworks that are used in palliative care, like patient-level care frameworks, patient-centered care, or the care delivery and practice frameworks like the gold standards framework, or the system and context frameworks like the WHO public health model or ecological systems framework, we realize that this impact framework is compatible with that. What it reminds everyone who's working is, please make the context mechanism and outcome pathway clear. What is it that we want to achieve with the patient, and together come up with a theory of change and spell out the activities that would lead to the outcomes. With the gold standard framework, we can see, for example, if you want to ensure that patients are well and all the symptoms are controlled, or enabling patients to live and die in their preferred place, it's inevitable to engage with the patient. And that way you develop that theory of change. So whether we want to say this attributed, so attribution, we are saying this intervention solely led to those outcomes, you need a theory of change. If we want to say this intervention contributed to these outcomes, you still need a theory of change. So we know that it's ideally, if you have an intervention and you want to demonstrate impact, you need to have a counterfactual. But by embedding these impact-aware methods at design stage, this enables you to demonstrate impact because you have a before and after state. So the theory of change fills the missing middle by, as we said, identifying the desired goal and working backwards to identify, okay, what are the outcomes that are needed? What is the mechanism? And what are the assumptions? The second central tenet is stakeholder engagement. It's worth to say that stakeholder engagement is a continuum, and very often people just do inform a patient. That's not sufficient if we want to achieve impact, or they consult the patient. That too is not sufficient if we want to achieve impact. If we want to achieve impact, we need to go beyond that and involve, collaborate, and empower the patient. And the stakeholder engagement, as we can see, also takes into account the context. In what context are we dealing with? Is this a patient that wants to die peacefully in their home? So you can see together they develop this theory of change and ensure that dignity and comfort is accorded, that the person, as we can see, there are moments of care, which is really deeply personal, and also that human connection, that gentle interaction, as we can see, between the nurse and the patient, highlighting both the patient and the nurse have come up with this theory of change and intervention, and it's working. The patient is very happy and feels well. With the central tenets 3, 5, and 6, we're talking about baseline, midline, and endline. As I said, it's so important to have at least 3 data points to do a trend analysis. And as using that example, we see that the patient is in pain, and she will tell you, I'm in severe pain. So that voice is so important. But you also use the pain scale. So you have both quantitative and qualitative data, which is so important for triangulation. And then you check how the patient is doing after initiating the intervention, and I also check at the end and see, have we achieved the objective in the patient? And you have set an objective. They want to be pain-free. So this really the importance of the 3 data points cannot be overemphasized as evidence that the intervention is working or not working. Because you might start with an intervention and you might end up with the same picture, the patient in pain, and that would mean this intervention is not working and it has to be discontinued. So this framework enables one to identify what is working, but also what is not working. So when care is reactive instead of co-designed and proactive, we say that impact is missed. So for example, if baseline measurements are not done, people are very busy and there are time constraints, then another person comes, you don't know, how was the patient before? There's no data for that. And also if we have the crisis-led interventions, you're putting fires out and you hardly can track what is going on. And then this leads to this poor quality of life outcomes and a loss of patient dignity. The central tenet 4 is mixed methods. I touched on that, the importance of really using both quantitative and qualitative data. This is because in epidemiological studies, we often fail to capture complexity of population health interventions, and mixed methods.
Janet,
yes.
Sorry to interrupt. I just wanted to let you know that we have about 20 minutes left in this
20?
webinar. Yeah,
oh,
so
okay,
if you,
okay.
So I don't know whether you could like.
Yeah, I'm coming to an end. Let me just give me 3 minutes. Yeah.
Of course. Thank you.
Thanks. So impact is not silent. It can be seen, it can be heard, and it can also, as you can see in end of life care. So with sources of data, it's important to use also the secondary data. So there's no need to come up with new data collection, because if we utilize a patient record, for example, we might just need to adapt and make sure that it captures the intervention theory of change, the intervention theory, and also what the patient says, so that we have both the quantitative and qualitative data. And the validation is important because researchers might say we have a 9 and they run and publish, but if you run it past the community, they will say, no, this is a 6. And this fosters advocacy and accountability. So this framework has got this engagement with the stakeholders at every step of the way. And what I said before, how we are doing research, we can see that these steps are actually complementary. The challenge is, for example, with modeling, there is an HIV model or HIV models that said no HIV by 2030. What happened there was they did not engage with the local stakeholders. Had they done so, they would have also identified that their assumptions were wrong, because people go, for example, in South Africa to the traditional healer. When they don't have money, they cannot go to the clinic to get their drugs. So it's so important to make sure that the stakeholder assumptions are involved. So impact is a journey which starts with impact thinking, becomes impact aware, and then you are then at the end are able to say, have we achieved impact or not? So if we don't crack this box, we will not even talk about sustainability or transformation. And it's for all areas in research. It's good for downward accountability, upward accountability, advocacy, learning what works, what doesn't, and co-creation. And the target groups are everyone. So the framework is rigorous yet accessible and demonstrates attribution or contribution and inclusive by design. And it creates room for everyone at the table. I'll just say the most important thing is that you need to use all these tenets, not singularly. So if you just develop a theory of change alone without the others, you are not able to demonstrate impact. That's something I really wanted to stress. And food for thought, is it really all about profit? Is it really all about career? Is it really all about climbing the ladder? One sure thing is that each one of us will one day face is the end of our own lives. So how can we bring humanity back to care? Thank you very much. And I just want to say that research and interventions that do not lead to positive outcomes can only be identified, re-examined, or discontinued if we intentionally and consistently track impact. Thank you.
Thank you, Janet, and sorry for cutting you off. I just wanted to make sure that if people have questions, they are able to ask them. So please, everyone, if you have questions, I will enable now you can turn on your camera. Yes, perfect. So first of all, thank you for your insights into the potential of impact evaluation research and explaining the impact framework you developed. Are there any questions? Maybe, Janet, if you could stop sharing your screen, we might see.
Yes, I have. Okay. Now, is that okay?
There we go. Yeah, perfect.
Thanks.
All right. Ben, please go ahead.
Yeah. Thanks a lot for the presentation. It was really lovely to hear, and you have a lot more to tell, I'm sure. I think I might want to start off the Q&A session, but because I had a question concerning the final point, you were starting to talk about mixed methods as one of your central tenets for achieving impact. And I wondered if the use of qualitative and quantitative techniques is necessary, you believe, to achieve impact, or if it's more a case that you need a broad or rich data analysis. And I wondered if multi-method analysis is also enough, or is also a good way to achieve impact. It's not to say that I have a preference for either, because I believe that quantitative methods can have an impact on furthering your reach, or because I was wondering what is the logic behind mixed methods specifically.
Yeah.
So that's my question.
Yes, I'll take that one. Thank you so much. So it's when we're talking about impact, we are saying, how have you changed the lives of the people? So the how already dictates that you also need to have qualitative data, because you want the people whose lives have been changed saying how their lives have been changed. So if you present a trend analysis and I see, for example, you want to improve access to healthcare services, and I see more people attending, let's say, healthcare facilities, we don't know what else is going on there. Is it because there was an influx of refugees or another population group, and that has led to that increase that we are seeing? But if we have the qualitative data and you are talking to the people, we will understand whether they said, okay, because of this intervention, I'm now visiting the clinic more regularly. And that's easier for you to triangulate. So it's actually important. It doesn't matter if you don't have to necessarily have the qualitative skills. It fosters collaboration. So the whole thing about impact is it fosters collaboration between quantitative and qualitative researchers. So you can invite somebody else and design this study together, but making sure, if you really want to make sure that you demonstrate impact beyond any reasonable doubt, then involve another researcher who has the qualitative skills, and mixed methods is the way.
All right, thank you.
Thank you for that question.
I see a question in the chat, and I think Melissa raised her hand. Melissa, you can turn on your yeah, perfect. Thank you.
Hi. Thank you so much. This was great. My question is just in thinking about study design, when you are, you need to apply for a grant and justify, your sustainability question, how do you start thinking about what outcomes can I include that are really important to thinking about impact that may kind of go beyond the scope of your study implementation period, that you can't actually present in your results until much later down the road? How do you balance that in like the early stages of study design? Thank you.
Yes. That's a very important question, and also that's also a question that comes up. Most of these studies are funded for only 3 years, and you cannot really demonstrate impact of an intervention within that 3-year cycle. And so what I'm doing here in Switzerland is also now talking to the funders and saying the researchers have identified that they cannot, and the funders themselves are also saying, they send me these reports and saying, we have achieved this impact, but when you go there on the ground, you realize that there is nothing, or they haven't really achieved that. So I think discussions like this, impact dialogues like this will help. That's why I started in the background with what is going on, where people are fudging numbers just because they want to get funding. And we can only move away from that by having these honest discussions with funders and decision makers. So for example,